Assalamu alaikum. Good morning, everybody. Our session today for dental imaging activity with the webinar with the speaker, international speaker, Dr. Nashi Aboud, the SCSD, the DFE. The topic, the effectiveness of lateral and vertical ridge augmentation, a 2020 update. Dr. Nashi Aboud, the specialist in periodontology, limited private practice and to periodontology, implantology, oral surgery, and advanced regeneration procedure. Dr. Naji, thank you so much for your time. The mic with you.
Okay, good morning, everybody. Good morning, everybody. I hope you are all listening to my voice, as I'm not listening to myself here. No problem. First of all, I would like to thank Dr. Jamal again for the invitation. This is my second webinar for SEHA, Abu Dhabi, and I am very happy to be with you again. Okay, always happy. So today we will discuss bone grafting. We will talk about lateral, and we will talk about a more complicated procedure, which is the vertical ridge augmentation. We will talk about many techniques like guided bone regeneration, like onlay bone grafts. Okay, and you will be able at the end to know better about the subject on which technique will be better for each specific situation. So we will start by classifying the bone loss architecture. We have the lateral bone loss architecture, where one of the walls is missing. It can be the buccal wall, and it can be the palatal or the lingual wall. We have the 3D bone loss architecture, where both tables are missing, the buccal and the lingual or the palatal at the same time. And we have the vertical bone regeneration, the vertical bone, the bone loss, I mean, vertical bone loss, where the bone lost a lot of its presence vertically in a wide area. The most common area is the posterior mandible, where the loss of vertical height will guide us to regenerate bone, because as you know, there is the nerve there, and it's very difficult to place an implant if we don't have bone in a vertical way. We will start our presentation with a case of buccal lateral ridge defect. Never place an implant in the upper anterior region without a CBCT or a 3D, because always the soft tissues here, in most of the cases, they are thick, and they can hide a bone loss in the area. So by looking at this case, we see a thick tissues around the area where we'll have to place an implant in the area of the upper lateral right incisor. But our 3D showed that we don't have this amount of width in the bone. And you can see live here that the amount of bone is not more than 1 millimeter. So 1 millimeter of width, there is no way to place the implant. In this case, either we can place the implant and do the regeneration at the same time, or do it with different steps. And this is what I prefer. I don't like personally to do everything at once, because whenever you are doing complicated procedures at once, you are adding a lot of risks at the same time. As you know, placing an implant, it has like 93, 94% or 95% of success rate. So we have a 5% risk of having a problem. doing a bone regeneration, it's like an 85 to 88% success. So we have a like maybe 10 to 12% of complications. So whenever we do those two procedures at the same time, we will add 5% to the 12%. So we are now at risk of 17%. So this is a lot. And sometimes when we do bone regeneration, we have a bone regeneration to 100%, so we can regenerate 100% of the bone loss. Sometimes we have a regeneration of 80%, and sometimes 90%, so it depends. So if we do the regeneration and we place the implant at the same time, and we don't have a complete regeneration, so we have the implant osteointegrated and the bone do not cover completely the implant, and here also we have a problem. So my preference goes to do the regeneration, then place the implant after 8 to 9 months. So as you can see here, of course, our flap must be distant from the regeneration area. In this case, we are doing lateral bone regeneration. It will be one tooth on the mesial side away and one tooth on the distal side away. We have to remove all the soft tissues from the bone, and we have to do those small perforations in the area where we want our regeneration to happen. Why we do those perforations? Because we need to have more blood coming out of the bone. So more blood, more bone cells coming out towards our graft. This is an occlusal view. This is our bone that was placed here. It is 80% made of xenograft, which is bovine bone, and 20% of autogenous bone. Why 20%? Because in this area, I used my bone scraper. I removed some bone from the area around my regeneration area, and I mixed them with my xenograft. Can we do this surgery with only xenograft? Yes, we can. We can do a lateral bone regeneration with 100% of xenograft. Adding autogenous bone will speed up our regeneration, okay? If we don't place autogenous bone, it can work, but we need a little bit more time to have our regeneration finished. So our membrane is stabilized from the palatal side with pins or screws. This is a collagen membrane. This is our mixture of bone that was placed in the area, and we close back the membrane. We tack it. Our membrane is trimmed to fill the area exactly as we want, and this is called the sausage technique. What is the sausage technique? So we place the bone, we close the membrane, we fix the membrane with tacks or screws, and we continue on adding bone while the membrane is already fixed, and this is called the sausage technique. One of the most important features in the surgery is the sutures. The sutures, actually, it's a combination of separate sutures and horizontal matrix suture. We have to start our suturing by doing the horizontal matrix suture, which is a suture that brings a lot of connective tissue to each other from the palatal and from the buccal flap. Then we do our separate sutures. So we have two separate sutures on the crest from each side of the horizontal matrix suture, and we have separate sutures on to close the vertical incisions that we did. We waited for 8 months. Then we opened back, we removed our tacks, and we can see the bone that we obtained. Okay, it is like 8.5 millimeter in width. As you remember, it was 1 millimeter. We obtained now 8.5 millimeter, which is a great result. So we could place our implant in ideal position. Our ideal position is to place the implant and be able to angulate it in a way to do a screw retained crown. Okay, it's not always the case because it's very difficult to have an implant where we can have a screw retained crown on it, especially in the upper anterior sector, because the bone is tilted towards the palatal. But because we could gain a lot of bone in this case, so we could do this procedure like I'm telling you. So the implant is in place. So you can see here our 3 pictures from day 0 with 1 millimeter of width, after 8 months with 8.5 millimeter of bone width, and our implant that is placed in ideal position later on. Okay, so this was before and this is after. This is a buccal view. In an article by Mendoza and collaborators in the Journal of Clinical Implant Dentistry, he was actually showing that if our guided bone regeneration could be done with or without autogenous block grafts. And in his findings, it indicated that guided bone regeneration with or without autogenous bone blocks is an effective approach. Okay, so it is the horizontal ridge augmentation or the lateral ridge augmentation, like I was telling you at the start. Okay, this is another case of lateral ridge regeneration. So this is a patient that was referred to me by an orthodontist. And as you can see, she has missing upper lateral incisor, congenitally missing upper lateral incisor. And in those cases, because we don't have an eruption of the permanent tooth, always the width of the bone in the areas of the missing teeth is always not sufficient, because in general the eruption of the permanent teeth will actually put the 2 walls, the buccal and the palatal wall, away from each other, and this is how we can have bone width. So whenever we have the permanent teeth that actually didn't erupt, the buccal and the palatal wall are too close to each other, and in the majority of the cases we have to regenerate the bone because it's not sufficient to place implants. So this is the patient face, okay, the missing laterals. So this is the case. Of course, before starting our surgery, all our x-rays, the PAs, the panoramic x-ray, and the 3D must always be ready, and we must take good care of taking a look at them before we start. We have to evaluate the distance on the 2 lateral side. It has to be really equivalent on the left, on the right side, because in a lot of cases the orthodontist cannot give us spaces very easily. So sometimes the space is 1 millimeter bigger on the left side than on the right side, or vice versa. So we have to be really strict about this situation. So the 3D showed that in the area of 12, the upper right lateral incisor, you can see the lack of bone on the buccal and the palatal direction, and we can see the same thing on number 22. Okay, so the bone loss is more severe on 22, a little bit more. So of course we wanted to do a bone regeneration prior to the surgery. We will not do bone regeneration and implants at the same time. So vertical incisions, 2 teeth away from each side, crestal incision in the area of the regeneration, removal of the soft tissues. I do it with this round burr with high speed. Then preparation of the bone with those small holes that I showed you before, left and right sides, and the bone placement. Okay. In this case, I wanted to compare 2 guided bone regeneration techniques, the sausage technique and the normal guided bone regeneration. So what's the difference? As I told you before, the sausage technique is whenever we place the bone, we close the membrane, we tack it, and we continue unpacking bone under the membrane, while the normal guided bone regeneration, the one we learned while doing my specialty, it is just placing the bone and closing the membrane over the bone. So 2 different techniques for the same patient. And of course, we closed everything. Everything was completely sutures hermetically. And like I told you, it was a combination of horizontal matrix sutures and separate sutures. This is the X-ray that was taken after 8 to 9 months. We re-entered again. This is after 9 months. So these are the two places, the two regions where we did our regeneration. The upper one is the sausage technique on the upper right, and the lower one is the normal guided bone regeneration on the left side. And as you can see also the difference in width that we obtained. Even though in the normal GBR we obtained enough width to place an implant, in the sausage technique we obtained actually much more width of bone. So it is more efficient than the normal GBR. The tags were removed after 8 or 9 months. We placed 2 implants in ideal position, and the patient was referred back to the prosthodontist to continue on doing the final crowns. And this is the final situation. Okay, those were the implants in the lateral areas. We can observe a highly healthy tissues around the implants, papillas placed in the back in the original position, and the ceramic that was done on the teeth actually was really good, and it was actually corresponding to the exact color and shape of the missing teeth. So this is the view of the patient with her teeth. This is before and this is after. Same thing from, I will show it to you from all sides. Just to show you here that whenever we are doing bone regeneration, we must have the necessary instrumentation. And to have the necessary instrumentation, we need a lot of kits. Those are the kits that I use. On the upper left, this is the master pin from Meisinger. The upper right, this is the Profix. Those are fixation screws. Those are fixation pins. This is the Profix also, the fixation screw. This is Salvin, also tags. This is the Salvin screws. Okay, I have a lot of kits that I use sometimes for the same surgery, because sometimes I can place a pin with the master pin, I cannot place it with the Salvin, and vice versa. That's another case where this patient was referred to me also by another doctor. He has also missing lower incisors, even a lower left canine, congenitally missing, also upper right and upper left lateral incisors. And also you know now that whenever we have missing permanent teeth, we don't have enough width, so we have to do regeneration, and this is what was done. This is the 3D for this area, the lower anterior area. You can see that we have only 1 millimeter of bone width, so we must do regeneration. So the decision was to do bone regeneration in the lower part first. This is the picture of the bone width. You can see we only have 1 to 1.5 millimeter of bone width. So the best decision was to use the same area to do the regeneration. As you know, we have the chin area where we have thick bone on the apical side. So we removed two onlay grafts, and we placed them in the areas where the implants will be. Okay, so we placed those bone chips or those bone onlays in the exact position where our implants will be. We placed a mix of autogenous bone and xenograft around those onlay grafts. We closed everything, and we reopened after 6 months. Okay, for the onlay block grafts, we don't need more than 6 months, even though some studies showed that 4 months is actually sufficient to place an implant after an autogenous onlay block graft. And you can see the width of bone that we obtained in this area. So this was before, this is at time of surgery, and this is after surgery. We obtained really a big amount of bone on the buccal lingual direction. 3 implants were placed in ideal position, and the final crowns were placed later on. Here, our goal was to create a bone horizontally and not vertically, because in the lower incisor, there is no aesthetic indication to create vertically in this area. So he has implants, very tall implants, and really stable crowns. In this case, actually, I've done it since more than 20 years, and still until now, everything is stable. So that was before, and this is after. We placed also the upper implants and the upper crowns, and this is his final smile. In an article by Chapasco and collaborators in 2009, they showed comparative clinical study between many bone grafting procedures to show what procedure is actually giving us a better result. They did comparative study between onlay block bone graft, bone distraction, ridge splitting, guided bone regeneration. So their conclusions was that it was difficult to demonstrate that one surgical procedure offered better outcomes than other. And priority should be given to the procedures who are simpler and less invasive, involve less risk, complications, and reach their goals within the shortest time frame. So for each problem, we have sometimes many ways to proceed, many ways to regenerate the bone. So you have to choose what is more simpler, less invasive, but giving us very good result. Okay, so we don't have to use the simpler technique, but giving us lower results than what is needed. Okay, that's another case of a missing upper right central incisor. We started, so we had to do bone regeneration. As you can see, the width of the bone is not sufficient to place an implant. So we started by doing a frenectomy, but because you see that the frenum is really high in this area, and we cannot cover back our bone grafting with the buccal flap, and we will have a risk of exposure because of this frenum. So frenectomy was done at the start. The bone was prepared. Here we wanted to use an onlay block graft. We went to the chin area. We removed an onlay block graft. We fixed it on the buccal side here, where we wanted our implant to be. We put some bone particles around our onlay graft. We place bone particles in the area where we removed our onlay block graft. So to regenerate the bone again, maybe we need to remove another onlay block in the future. The temporary was placed, always fixed temporary over the bone regenerated area, and never a removable one, never, never, never. So here we placed a fixed temporary crown, which is a Maryland bridge away from the gum. Okay, so we opened again, we opened back, and we placed the implant. This is after 6 months. At this time, I was waiting for 6 months. Now we can do it after 4 months, and this is the final crown in place. The final crown was done after 3 months from implant placement. That's another case also where we have to do a regeneration in the upper anterior sector. Okay, we always start by doing our removal of soft tissues with our round burr. You can see the two concavities that we have in the area. Also, we went to the chin area. We removed our block bone grafts. Here, as you can see, we divided them into 3. Okay, we removed first, the second, and the third one. Okay, then we closed everything. We placed bone particles in the area where we removed the bone. Okay, we took one onlay block graft. We perforated with two holes to be able to fix it with screws, with mini screws. And we used the other two blocks. We broke them with our mill, okay, and we divided them into small particles, and we mixed them a little bit with xenograft, with bovine bone, and we placed everything under this onlay block block bone. Okay, this is another technique of doing onlay block grafts. It's not using one screw but two screws. So our onlay will be like a drawer. It can go out and inside, and our bone chips will be placed under it. We did this from both sides. So we closed and we reopened again after 6 months. Okay, you can see the quality of the bone. It is completely integrated in the area. So we removed the first screw, and here we are removing the second screw. This is from the right side, upper right area. And you can see also in this movie, the upper left area also, where we have really good amount of bone that was regenerated after this procedure. So the screw is removed and the implant is actually placed in optimal position. Okay, this is our implant ideal positioning. We have to take care of our angulation. If we can place the implant with an angulation that will let us do a screw retained crown, it will be much more better for the crown, because we are doing less and less cemented crowns over the implant to reduce our peri-implantitis risk. And peri-implantitis is actually a big subject, and if you want, we can do a presentation on the treatment of peri-implantitis. What are the current techniques in treating peri-implantitis? So the implant site is prepared. Okay. And we are also placing implants in the posterior side. We are doing everything at once. This is the area of 14, the area of 15, was the area of 12, where we did our regeneration, 12 and 22. I will just make the movie a little bit more fast. Okay. We are continuing our preparations on all sides, and this is our implant that is placed. This is, I think, a 4mm width implant. So this is the first, and this is the second one. This is number 14. Okay, this is number 15. This is number 17. Okay, and this is the closure of the flap. Okay. Okay. That's another case where also we have this patient, 23-year-old female patient, referred to me with a lot of congenitally missing teeth. You can see that the lower anterior incisors are missing. The upper right lateral incisor is missing. The upper left lateral incisor is missing. The upper left canine is missing. The upper premolar is missing. The upper left premolars. And on the right side, it is the same. So we have as permanent teeth, number 16, number 11, 21, 26, and 27. This is all that we have as a permanent teeth in the upper jaw. As for the lower jaw, you can see that we have only number 46, 45, 43, 33, 35. That was actually moved a little bit more medially, and number 36. Everything else was missing. And as I told you before, whenever we don't have eruption of permanent teeth, the width of the bone in general is not sufficient to place implants, so we have to do regeneration. So the decision in this case was to do regeneration in the lower anterior area, lower right area, upper left area, and upper right area. So This is the upper right and the upper left. The decision here was to do guided bone regeneration, and this is what was done. This is the upper left, and this is the upper right. As for the lower part, we did, like the case before, we used the same area to remove onlay block grafts. So we removed onlay block grafts from the chin area and we placed them in the areas where our implants will be. On the lower right area, we did guided bone regeneration. We closed everything with a collagen membrane and fixed with tacks, palatally, lingually, and buccally. Okay, everything was closed. So this is after 6 months. We can see here by transparency the fixation screw that we used on our onlay block grafts. And we open the flap again. You can see the start. It was like 1 millimeter of width. Now we have more than 6 to 7 millimeter of width. So our screws were removed and our implants were placed in ideal position. On the upper right and the upper left, the same thing. We waited like 8 months. Then we removed everything again after. So this was before and this is after. This is the right side. This is the left side also. This was before and this is after. And the implants were placed on both sides. So we now, in this case, placed the implants for this patient, and she was ready to receive the crowns later on. So it was 2 implants to replace the 4 missing lower incisors, 1 implant in the area of 44, 1 implant in the area of 35, and the upper implants to be able to create teeth again for this patient. That's another case also of a full mouth regeneration. This is a patient that came to our clinic. Of course, this is an edentulous patient. She had removable prosthesis since more than 10 years. And you can actually guess that removable dentures are an enemy of the bone, because whenever we have removable denture, we will have bone loss eventually after some years. Okay, our panoramic X-ray showed us that we really have a good amount of bone in the vertical dimension, but our panoramic X-ray will not be, of course, sufficient for us to do a treatment plan, and we needed 3D. And the 3D showed us that we don't have any width of bone in the upper and in the lower mandible. Okay, so the bone width in the upper jaw and the lower jaw was not more than 1 millimeter of width. So we had to create a lot of width in the upper and in the lower jaw. And this is what was done. So in the upper jaw, you see the 3D. Our implants actually were, we decided to place implants in the areas of 12, 14, 15, 16, 22, 24, 25, 26. In the area of 12, you can see we have like 0.5 millimeter of bone width. In the area of 14, not more. In the area of 15, we had like 2.5 millimeter of width. In the area of 16, we had width. In the area of 26, we had width. In the area of 25, we had like maybe 3.5 millimeter of bone. In the area of 24, 2 millimeter. In the area of 22, not more than 0.5. Also, in the lower jaw, we didn't have bone in the areas of 35 and 36, so we have to do also bone regeneration in this area. So this is the upper jaw. We started the upper jaw by removing some autogenous bone blocks from the chin sides. Okay, we removed as much bone as we could. We closed everything with autogenous, with a mix of bone particles in the mandible area where we removed our onlay block grafts. We sutured everything. And this is the upper jaw. We marked the bone exactly where our future implants will be to be able to regenerate. Here you can observe the width of the bone that we had, not more than 0.5. It was really too thin. And we could break it also whenever we were elevating the flap. Okay, so we had to be very careful while elevating the flap. The bone was really too thin. So we marked where our implants will be, and we used our onlay block grafts in the areas of 12 and 22. Okay, so it is the drawer technique. Okay, so we broke a part of the autogenous bone to place them as particles under our onlay block, fixed with 2 screws. And we did the guided bone regeneration on the upper right and the upper left sector. As for the lower part, we did also guided bone regeneration on the areas of 35 and 36, and this was before our regeneration, and the X-ray, the 3D down, is after 8 months. So this was before and this is after. In the areas of 12 and 22, that was before, and this is after, before and after. We created enough bone width to be able to place the implant. This is number 24, imagine before, and this is after, with guided bone regeneration. So onlay block grafts in the areas in the upper lateral incisor area, and everything was elsewhere was guided bone regeneration. We reopened again after 8 months, and we could place 4 implants on the upper right and 4 implants on the upper left. Okay, you can see that we have enough bone width everywhere. These are the sutures, and the lower implants were placed, and we had also enough bone in the areas of 35 and 36 to be able to place the implants. And those were the final crowns that were done by the prosthodontist. The patient in this case chose a very whitish color. I don't know what happened to her. She wanted to become young again. So that's another case where we had a 3D ridge defect. A 3D ridge defect, like I showed you at the start. We have missing the buccal, and the palatal walls are missing. Okay, you can see here that the buccal and the palatal walls are not existent. So we went first to the ramus area. We removed an onlay block graft from the ramus area. Okay, why the ramus area? Because it's the most simple area to remove the bone blocks with. We divided the bone block into 2. Okay, you can see that we are dividing it into 2. We collected also bone chips with our bone scraper from the same area. We closed the donor side before we went to the reception side. We prepared the bone, our bone onlay blocks with small holes, and we fixed our onlay block bones, one from the buccal side and the other one from the palatal side. One buccal side and one palatal side. And we used our bone chips, the one that we collected with our bone scraper, and we mixed it with autogenous bone, and we placed them between the 2 onlay blocks, the buccal and the palatal wall. We closed everything with a membrane, and the sutures also, they were like I showed you before. This is the membrane. It was also a combination of matrix and separate sutures. So now we are starting our vertical ridge defects regeneration. In those cases, the only technique that we can use until today, and the most efficient one, is the guided bone regeneration. There is also the Khoury technique with onlay block grafts. Personally, I don't do it because my work is in a private clinic, and personally, I think that it is a little bit traumatic to the patient, and it's better to do it in a hospital premises. So this patient was referred to me. He had a car accident, and you can see the tissue loss that he had in the lower anterior sector. So the dentist that referred to me this patient, actually he places his own implants, but I do the regeneration for him. So the patient was referred to me like maybe I think 2 years ago. And here you can observe how much tissue loss we had. Okay, so we open the flap, 2 teeth away from each side, vertical incision. Here we can observe that we have 9 millimeter of vertical tissue loss, vertical bone loss. Okay, so we had to regenerate as much bone as we could to be able to fill this gap. The bone was prepared, removal of soft tissues, and small perforation to enhance the blood flow coming out of the bone. Always when we do vertical bone regeneration, we must use non-resorbable membranes and with a titanium infrastructure. Okay. So also we use a mix of autogenous and bovine bone. The mix is like 50-50, 50% of autogenous bone and 50% of bovine bone. So the titanium reinforced membrane was firstly fixed from the lingual side. The bone was placed, then we closed the membrane on the buccal sides. We used, in this case, many fixation screws. Okay, we used like maybe 3 or 2 on the lingual side and 4, as you can see here, from the buccal sides. So everything was closed. We must always rest our flaps from the buccal and the lingual side, pacify our flaps to be able to close hermetically over our regenerated area. And this picture is taken after this X-ray, this panoramic X-ray was taken after 9 months. And here you can see in each area how much bone we created. In the area of 41, we created more than 5 to 7 millimeter of bone vertically and more than 7 millimeter horizontally. In the area of 43, we created 9 millimeter vertically and more than 6 millimeter horizontally. In the area of 42, we created 7 millimeter vertically, 6 millimeter horizontally. In the area of 31, it was like 4 millimeter vertically and 5 millimeter horizontally. So this was the situation before surgery, and this is how we referred back our patient to the doctor to be able to place for him the implants in exact position. Okay, so we created more than 8 millimeter of bone vertically in this case. That's another case of vertical regeneration. Also, this patient was referred to me by her dentist some years ago, maybe 4 years ago, I think. And she came to me in this situation: a temporary bridge with a buccal flange. It was like hiding something. Okay, so the patient came to me. Of course, I removed the temporary, and we can see a big amount of tissue loss vertically. Okay, the patient told me that she had a car accident, and this is what happened to her. Here now we can see that we have a bigger problem. The bigger problem is that the patient already had implants placed in this area in a very apical position. Imagine this patient, a 30-year-old female patient. She was a beautiful, and she was a working lady. Imagine having two crowns here that were more apical. Imagine having a upper left central incisor which was like 6 or 7 millimeter higher than number 11, than the upper right central incisor. And even the lateral incisor on 22 was higher than 21. So imagine the aesthetics that we will obtain after placing the crowns in this situation. So the patient actually knew that something wrong was gonna happen, and this is why she changed her dentist to another one, and he referred then her to me to be able to fix that. This is the X-ray. The implants were completely osteointegrated, but as you know, in a very apical position. The 3D showed that even the implants were osteointegrated, we didn't have buccal bone on the implants. So imagine on those implants, the very apical position of the implants, even with the apical position of the implants, we didn't have any bone on the buccal side. So imagine where the buccal bone was, maybe like 10 to 12 millimeters more apical than the exact position. Okay, so our treatment plan was to remove the 2 implants as a start, to extract number 11, to do a vertical and horizontal bone regeneration in the area, to do crown lengthening on the right and left teeth to be able to match the 2 levels, because she had also a gummy smile, which we can take an advantage to do a crown lengthening on the left and on the right side to reduce the crown lengthening and to be able to bring our level a little bit more apically on both sides, and to match our level in the anterior region that we will try to bring more coronally. Okay, and then the prosthetic treatment at the end. So we started by removing the 2 implants. I have special instrumentation and special devices to remove implants without opening a flap. So the 2 implants were removed. Okay, and we wanted to, normally we wanted to extract number 11 also, because number 11 actually, it had an infection and it was a very small root, so we had to remove it. But whenever I saw that we had some tissues on the mesial part of 11, so we thought that maybe we could take advantage of the bone that was existing on the mesial part of 11 to create bone in the area of 21 and 22, because whenever we have bone laterally, it was much more easy to migrate the bone cells laterally in this area than to migrate bone vertically from this area. Okay, so we said, let's keep number 11 for now, regenerate the bone, then remove number 11 later on whenever we will place the implants. So we left number 11, we opened the flap again. So whenever our flap was open, we had a bad surprise, because the infection that was showing on the X-ray on number 11, that was showing that it was apical, it was also mesial, and it was reaching the area where our bone will be, our bone particles will be, because our regeneration will be in this area. So the infection was reaching our bone area where we place our bone grafting. So it was, there was no way to do the regeneration at this step. So we only did an extraction of number 11, and we cleaned the area from the infection, and we closed again. There was no way to take a risk again for this patient. We cannot take any risk when doing this regeneration. So we closed again, and we went back after 1.5 months. Why always 1.5 months? 1.5 months, this is the time needed for the complete regeneration of soft tissues. We need a complete regeneration of soft tissues before we can do any regeneration, because we need the soft tissue to close completely over our regenerated area, and they have to be mature. So 6 weeks later on, same incision in the same area, 2 teeth away from each side vertically, crestal incision in the area of the regeneration, and imagine the vertical tissue loss that we have. Okay, so we opened again, and here you can observe how much bone loss we have. We had like 12 millimeter of buccal vertical bone loss. We had 6 millimeter of palatal vertical bone loss. I'm not talking about the lateral bone loss. So of course, to regenerate vertically, we need 50% minimum of autogenous bone. The best area to remove from is the ramus area. So we removed bone. We made it as chips. So we used our bone meal. We used, of course, a titanium reinforced non-resorbable membrane. We fixed it palatally with maybe 3 or 4 fixation screws. We placed the bone. We filled the area where we needed. Okay, so we filled everything with the mix of bone, 50-50, 50% autogenous and 50% of bovine bone. We closed the membrane over the regenerated area. And also it was a sausage technique, so we continued on placing bone under the membrane whenever it was stacked on the buccal side also. Same sutures, okay, a combination of separated and horizontal matrix sutures. The patient traveled for 9 months and she came back after 9 months. Here we can observe that she has a lot of plaque in this area. Why she had a lot of plaque? Because we can understand the psychology of those patients. They are always afraid to come near to the area where we regenerated the bone. Even though we told her that you have to brush very well, she was really afraid. Nevertheless, the amount of tissues that we created after this surgery was really tremendous, okay? And we were very happy about the results. So our decision was to do as before. We had to open, we have to remove the membrane, to remove the tags, do crown lengthening on the lateral sides, right and left. So remove the membrane. And here you can observe the amount of bone that you obtained. That was before, and this is after 8 months or 9 months. Okay, you can see how much bone we obtained vertically and laterally. The crown lengthening has started here. We always have to do the crown lengthening and the osteotomy before we place the implants to know exactly where to place the implants. So the osteotomy was done in the areas of the crown lengthening, left and right. The 2 implants were marked where they will be. Okay, 2 implants were placed. Then a temporary bridge was placed over the implants. Okay, and this is another set of temporaries that the dentist was fabricating for the patient, and he was manipulating the pontics to be able to create papillas as much as he can. Now we will start by talking about the vertical guided bone regeneration in the posterior mandible, which is one of the most complicated surgeries existent for any patient in our clinics. To be able to do this procedure, first, of course, we have to do horizontal and vertical incisions. We have to dissect the mental nerve. Always dissect the mental nerve. We cannot leave it without dissection because the flap will not close over the regenerated area. We have to prepare the reception site by removing all the soft tissues and doing those small holes in the bone. We have to liberate the lingual flap to be able to make it more coronal of 10 to 15 millimeters. Yes, 10 to 15 millimeters. We have to test the labial liberated flap. Then we have to harvest bone from the same area, from the ramus area, and we have to mix it with bovine bone. The most tricky thing in this surgery is the fixation of the lingually of the titanium reinforced membrane. It's really complicated. And then the buccal fixation of this membrane and the complete closure. So as you can see here, we opened the flap. We didn't pacify yet the lingual flap, and you can see how much the lingual flap can come buccally. So our passivation can be done with many techniques. Here, I'm working with a non-working site of of the blade, okay? Because if we work with the other side, we can have a tearing in the flap, or we can have a trauma for the vascularization in this area or the innervation in this area, because the lingual nerve is really too close. The fixation of the membrane, okay, here we are doing it with pins, but it is not more common to do it with pins, because in the majority of the cases, the bone angulation here is really difficult, and we can do it only with fixation screws. Okay, so I will show you this case. Okay, we'll start from here. So this was a case that I did. Okay, we had to extract number 47 that was tilted mesially. We had to do implants here and bone splitting at the same time. Okay, but the case was that we had an infection and the bone actually disappeared. So we had this vertical bone loss. Okay, so the only way to create bone again is to do vertical bone regeneration with a titanium reinforced membrane, and this is what was done. This was before, and this is after. Before and after. This is before and after. So this was before, this is after the infection, and this is after our vertical bone regeneration. Okay, this is the case, showing it to you again. So the implants were placed at the start. We did bone splitting, but the thing happened that we had an infection in this area, and we lost all the bone and all the implants at the same time. And this is why we had this infection. We had 12 millimeter of vertical tissue height. Those are the incision that was really necessary to do the vertical bone regeneration. This is the lingual flap passivation, 17 millimeter vertical displacement. This is the bone that was collected by the bone scraper. Titanium reinforced membrane, mix of bone, 50-50, placed, membrane tacked from the lingual and the buccal sides. Combination of U-shaped sutures and separate sutures. The U-shaped sutures are the horizontal matrix sutures. Okay, so that was before. This is 9 months after. We went inside again. This is the width that we obtained. And 4 implants were placed in ideal position again. Okay, this is a more complicated situation. This patient was actually consulted me maybe 3 years ago. He told me that he went to many dentists because he wanted to have a fixed solution in the lower jaw, and he couldn't have because there was no bone on the right and on the left side. You can see that the height of bone here is really not sufficient to place any implant. It was like maybe 4 to 5 millimeters above the dental nerve. So the decision was to do a vertical bone regeneration on the right side and on the left side. We did them on 2 consecutive days. Okay, this is the left side, okay, and this is the right side. So this is 9 months after. We can see that the bone we created in this area, we wanted to create bone here in the areas of 36 and 37 because on 35 there was no way to place an implant. 33 was to be extracted later on, so implant on 33, 34, 36, 37, and in this area we needed to place implant on number 45, 46, and 47. So here you can observe how much amount of bone we created vertically. In the area of 36, we had like 5.3 at the start. We obtained 10.2 after doing our regeneration. In the area of 37, we had like 5. We had like 10.9 after the surgery. In the areas of 45, we had 5.9 before, then we had 8.8. In the area of 46, we had 6.3, it was 9.5, then 4.2, we had 7.4. So we created bone vertically in all the areas. So the time was now to remove our membrane 9 months after. And you can see the amount of bone that we created. This is the left side. 4 implants were placed. As I told you, 33, 34, 36, and 37. This is the right side. You can see the amount of bone we created vertically. This is all new bone, new bone, new bone vertically. 3 implants were placed in ideal position. Okay, so that was before. This is after our vertical regeneration. This is our implant placement in ideal position after 9 months. And these are the final crowns. Okay, those are the crowns, all screw retained crowns. This is an article by Alessandro Cucci showing 2 techniques in vertical bone regeneration, one using a non-resorbable membrane, titanium reinforced, and the other one showing the use of a combination of titanium mesh and resorbable membrane, showing the complications and the success rate. And in all cases, he didn't see too much difference between the 2 techniques. So the 2 techniques were really acceptable. So to conclude our presentation, and for you to be able to think better in those cases, we can make this this table. So this is the lateral, this is the 3D, and this is vertical bone loss. So whenever we had to do a lateral regeneration, our incision must be crestal. So in the 3 techniques, the incision is crestal. We don't do any more buccal or lingual incision like we did before. The flap elevation must be full thickness in all 3 techniques. The autogenous bone, we can do lateral bone regeneration without using autogenous bone, but we must use autogenous bone whenever we have to do 3D and vertical bone regeneration. We have to stabilize the membrane in all the 3 techniques. We have to pacify the buccal flap in the lateral and in the 3D, while we have to pacify the buccal and the lingual flap when we do vertical bone regeneration, especially in the lower mandible. We can use bone blocks to do lateral and 3D, but we cannot use bone blocks to do vertical. So to do vertical, in the majority of the cases, it is guided bone regeneration. We have to wait for 8 months for lateral and 3D, and we have to wait for 8 to 9 months for vertical. The membrane type for the lateral, it's collagen, and it is PTFE metal reinforced for 3D and vertical. PTFE stands for polytetrafluoroethylene, titanium reinforced non-resorbable membrane. The infection risk is low for the lateral regeneration, while it's medium for 3D and it's high for the vertical regeneration. So you have to be careful. The lateral bone regeneration, it has a high sensitivity in the technique, so it depends a lot from the surgeon and the ability of the surgeon. It is more sensitive to the surgeon in the 3D, and it is too sensitive for the surgeon in the vertical regeneration. Okay. So to conclude, we can say that a predictable implant treatment with a long prognosis can be obtained only when enough healthy soft and hard tissues are present. So never place an implant whenever the tissues are not sufficient. Okay, hard and soft tissues must always be sufficient to place an implant and to be able to have a long prognosis and to have a happy patient, because an unhappy patient will come back to you after with a lot of problems. Soft and hard tissue must be augmented when needed prior to implant placement to decrease the risks to the maximum. And soft and hard tissue graftings are really technique sensitive. And I would like to thank you for your attention. If anyone would like to ask me any question or get in contact with me, you can do it through Facebook or through Instagram. Okay. Thank you all, and I will be here with you now if you want to ask me any question.
Thank you, Dr. Naji. Thank you so much. Any question, please?